All right. Hello, everybody. My name is Rob Werstein. I'm one of the co-principals for Key Clinical Skills, and I'd like to welcome you to another one of our free webinar offerings. I am very pleased to introduce I'm very pleased to introduce for the vestibular education program today, Kregg Ochitwa, who is kind enough to talk to us about nystagmus. And so Kregg is a graduate of the U of Sask back in 1995, and he's been in private practice now for over 20 years, and has started about 20 years ago to specialize more in seeing people with dizziness. And because this is a growing problem, which is so poorly treated, his caseloads exploded. And in 2010, he opened North 49, which is a clinic which specializes in vestibular issues. And Kregg's continued to do a whole bunch of vestibular therapy education and has completed the prestigious Emory Medical School program on vestibular and dizziness. And he also has been sharing his knowledge with physios in Western Canada for the last few years. And we're very pleased to have him here today, offering some explanations around the black hole that I would call dizziness when we're dealing with people with vestibular and or concussion and or other related problems. So Kregg, take it away. Thanks very much for joining us.
Awesome. Thanks, Rob. Hey, excited to be here. It gets me out of the mask with COVID, and it's kind of nice doing things from home. So I'm excited to be here, something I like talking about. And this is the first time I've done a webinar for Key Clinical Skills. And I was looking through their website just last night. They have some pretty cool courses we were talking about before this webinar started. So, take a look at their website. They got some pretty good things going on there. What we're going to talk about today it's called These Eyes Don't Lie. 3 ways to determine if nystagmus with dizziness is a red flag. And really, this webinar is for you guys. If you guys have any questions, feel free to put in the chat, and Rob will kind of, interrupt me and say, hey, there's a question from so-and-so, and he'll read it to me. And I may answer it then, or I may answer it at the end. But this is for you guys, so let's get as much as we can out of it. And questions are good, because when I start talking, sometimes I just start talking real fast, and sometimes it just gets me slowing down. Really, this webinar is for someone. I don't know if you guys ever second guess yourself when you see nystagmus. Is it nystagmus? Is it not? Or if I see nystagmus, is it something that I should be concerned about? When I went to school, nystagmus was a red flag, and I wasn't supposed to see people with nystagmus, nor was I actually supposed to treat anyone with dizziness. When I went to school way back, they said any 5 Ds or 2 Ns. I don't know if you guys remember 5 Ds. Dysarthria, dysphagia, drop attack, double vision, dizziness, all those things. We weren't supposed to treat that, but kind of ironically, over half my caseload consists of people who are dizzy and have nystagmus. So is it something we should be concerned about? Or are you just interested in the field of vestibular therapy? Like Rob said, it's a growing and much needed growing field. Or sometimes physios, we're life learners. It's just something you're interested in. That's cool too. So, this is for you guys, and I want to share some information to help you improve your outcomes in patient care. So these are some of the objectives that I have. Hopefully by the end, you feel more comfortable analyzing nystagmus. You develop an understanding of how to use nystagmus to determine if the dizziness is conditioned from the brain or the inner ear, and have more confidence in knowing when to refer. So those are my objectives, but like I said a couple times, this is for you guys. If you can, in the chat, just if I've missed something, any objective that you guys want me to cover, that would be great. That way we can kind of stick handle it and make sure that we're meeting the needs you guys have in a webinar format. So if you guys take some time and then Rob can kind of tell me what other objectives you guys have, that'd be awesome.
All right, thanks, Kregg. I've sent out a message to everybody in the chat that I'll field their questions, and I think we're good to go.
Yeah. Is anyone giving any extra objectives? We got a quiet bunch there.
Nothing yet.
They're probably still all coming in. Okay. All right. So let's keep motoring along here. So those are objectives, those things we want to cover today. So a bit about me, Rob kind of gave the rundown. I graduated from the University of Saskatchewan here in 1995. I've been working outpatient practice since then, and doing MSK stuff. Then about, 17, 18 years ago, started doing vestibular stuff, saw concussions from day one. And now over the years, my caseload has basically morphed into over half the caseload that we see in our clinic. So I opened up North 49 Physical Therapy in 2010. And under that umbrella, we have the North 49 Balance and Dizziness Centre. And that center has actually taken over half the patients that we see are dizzy. We see more dizzy patients than all our MSK combined. And we see over 100 new vestibular patients a month, like new ones. And for a population of 330,000 people with at least 12 other clinics that say they do vestibular therapy, there's a big need for vestibular therapy. So if this is something you want to get into, a niche market, definitely something worth getting into. That's kind of a bit about me professionally, but more importantly, that's my wife there of 28 years. My son on the left there is Luke. He's on a lacrosse scholarship down in South Carolina right now, playing lacrosse, taking exercise sciences. And then our oldest son, Zach, on the right side there, he's starting his master's degree. He started it in mechanical engineering and specifically robotics, and he's doing lots of medical robotic stuff. So yeah, so kind of interesting, awesome kids, awesome family. So pretty blessed that way. So that's about me family-wise. And this is the group, lovely group that I work with at North 49. Our team there, best group of people that I've ever worked with by far. So big shout out to them as well. So that's kind of me in a nutshell. Before we get too far, I kind of want to get a baseline for where you guys are at. Actually, I want to know, where are you guys from? I know Key Clinical Skills has people from all over the world. I'm just kind of curious to see, and I can't see the chat. So Rob, if you guys can text in the chat, which country you're from, or state or province, or just so we kind of have an idea where everyone's from, and Rob can just kind of.
Here it comes in. We've got some Florida, some Calgary, Toronto. Love the Florida. Jealous of the Florida right now. Niagara, Philadelphia, suburbs of Philly in the US. A couple more Toronto. Good. Calgary.
Nice.
We got a broad range.
Okay, so Western Canada, Eastern Canada, Northeast states there. That's pretty cool. Awesome. So yeah, thanks for joining me, guys, because time is precious, and you guys took an hour out. So it's an honor to serve you guys tonight. So what I want to do is get a baseline. Actually, I'll ask another question. Do you guys see vestibular patients? And maybe you give me 3 responses. No, I see some, or I see heaps of them. So no, some, or lots. Just kind of know where you guys are at with your understanding, a little bit of dizziness there.
Good. We've got broad range, a bunch of sums, a couple of people who see lots, and cool. Somebody who's about to jump in with both feet. So,
so we got people all throughout the spectrum, and this is a journey. Like, it's the thing about physio; we never stop learning, right? There's so many cool things, and so we got people across the spectrum here. So what we'll do is we'll go over some videos first, just to see what you got. You don't have to tell us in the chat, but just on a piece, get a sticky note, get a pen and paper, and I want you to write down, we got a couple of videos here, what you see, and then what do you think is causing the nystagmus, okay? So I'll hit play here. I'm not gonna coach anything or say anything, just what do you see? All right. So that was pretty fast, but what do you see and what do you think? And if you don't know, and if you don't know what you saw, That's totally fine too. That's what we're here for, okay? So we got another video here. Let's see what we see here on the next one. So these are actual patients that I've seen in clinic. These aren't something that I pulled off the web. Okay, what do you guys see with that? And what do you think is causing this nystagmus? And we're going to round out this circle and come back to those videos at the end. Okay. So what do you see with that last one, and what do you think? And if you don't know, that's cool too. Hopefully by the end of the seminar, you will know.
We got one answer. The second video from Helena there, she noted it was a downbeat nystagmus. The first one looked like
all right.
Lateral or overshoot.
Okay, we'll go over these. So yeah, downbeat, good call. Okay. So just some vestibular facts. We talked a bit about, like I said, we see lots of people that are dizzy in Saskatoon. And a lot of you guys are from bigger centers. So man, population is huge. So just some stats, more than a third of the adult population in the USA, 40 years of age or older, have experienced some form of vestibular disorder. On average, patients consult 4 to 5 doctors before receiving a diagnosis. And BPPV, which is the most common cause of dizziness across a lifespan, costs approximately $2,000 US, so well, even more Canadian, to diagnose, as over 65% of patients undergo unnecessary diagnostic testing or therapeutic interventions. Very similar to back pain, right? Common, isn't treated well, costs lots of money, right? So as healthcare providers, we can make a big impact on this, the cost and people's quality of life, if we're trained. And so this is kind of part of that. So just generally, what are some of the causes of dizziness? You know, it could be cardiovascular, visual, metabolic, mental health, cervicogenic, medication, vestibular. There's lots of reasons for someone to feel dizzy. I like this study. It's a bit old, but I like things simple. It kind of breaks down the cause of dizziness. So if you're a gambler, you know, 44% of the time it's going to be, if you roll the dice, just under half the time it's going to be an inner ear problem or peripheral vestibular. So if you hear me saying the word peripheral vestibular, in this case for this webinar, I'm talking about the inner ear. And if you hear me talk about central, that's talking about the brain and such. So inner ears, 44%, brain is less than 10. So the serious stuff isn't that common, but there is the risk of it being there, not that common. I should maybe change psychological factors, maybe say more mental health, stress, anxiety, 27%. So inner ears number 1, mental health number 2, right? Other non-vestibular or non-psychological, so that'd be like blood pressure, blood sugars, anemia, orthostatic hypotension, those types of things, medical things, 13%. There's always that line, other unknown, 13%. So inner ear is very common, stress and anxiety, medical, then the serious stuff, brain, is even lower than that. And if you add all these up, it's more than 100%. And the reason for that is a person can have more than one reason for their dizziness, okay? And that's what makes sometimes we have to be very good at our assessment and such, history and examination, tease things out. So that's kind of, you know, brief stats. I'm not going to bore you with stats, but just kind of how common it is. Nystagmus is really, that's what we're talking about tonight, a repetitive, uncontrolled eye motion. Usually affects both eyes. It could be constant, it could be intermittent, it could be temporary or permanent, depending on the cause. And it looks like a stuttering or flickering motion. It can be up, down, laterally. It can be torsional, or it can be a combination of these things. And sometimes we can see the nystagmus in room light, while other times we can't. So really, as healthcare providers, if we say we're doing vestibular therapy, we need to purchase a pair of infrared goggles, because that really helps us make sure we're not missing something, and helps us tease in a vestibular versus, a central vestibular versus a peripheral vestibular. And so we have actually 5 sets of goggles in our clinic. The last set we got were from Vestibular First in the northeastern states there. If you Google Vestibular First, you can get an excellent set of goggles, surprisingly exceptionally priced, like a fraction of the price we get elsewhere, and great customer service. And you'll see some pictures and videos of the Vestibular First. So if you need a set, Google Vestibular First. You'll be surprised how reasonable they are. Need goggles. So we talked about the cause of dizziness. Let's go over some of the causes of nystagmus. It could be conditions affecting the brain, the inner ear, neurological conditions in newborns. We don't see that clinically in an outpatient basis. Medication, alcohol, drug use, albinism, another reason too. But really when it comes down to it, what we see clinically, brain and inner ear is why people have nystagmus. You know, medication, drug, alcohol use affect the function of the brain and the inner ear. So it really comes down to brain and inner ear are the cause of nystagmus that we see. Albinism, don't see it, and clinically not really relevant. So what does nystagmus look like? Just laying some foundation before we get into the 3 things that we'll do to differentiate central versus peripheral. With left beat nystagmus, that can be from a central or peripheral vestibular condition. The sudden eye movement is to their left, or if we look at it on the video here, it's to the right. So this gentleman's laying here, and he's going to turn his head suddenly to the left, and then what happens to his eyes? They start flickering to our right of the screen, which is his left. Okay, remember it's relative to him. So that's left beat nystagmus. And the thing that caused it was a change of his head position. Okay, right beat nystagmus will be the opposite. There'll be the flicking to the left of our screen or to his right. And this side's a lot more obvious. Okay, I hope everyone can see that. So again, the change of his head position elicited nystagmus. In this case, it's right beat nystagmus. Okay. Downbeat nystagmus. Downbeat nystagmus, I'm going to steal some of my fire. Downbeat nystagmus is a central sign, and you'll see the jerking or the flickering downward. You just kind of see beating downward. Okay, it's just get you orientated. We saw left beat, right beat, downbeat. You can also see up and torsional. There's all sorts of variations, but we'll go over the common ones. So if you see right torsional nystagmus, upbeat right torsional, it looks like this. We're going to lay this person back in the right Dix Hall pike. Nothing, nothing. And then their eyes start flickering up. And they start flickering actually kind of counterclockwise, which is right torsional. Or if I can pause it here. Yeah, I can. Okay. I don't know if you can see my cursor on the top of her pupil. If you can find like a landmark, like a blood vessel or something with the pupil, and watch that, it'll actually flick, in this case, to her right or our left. Her eyelids aren't wide enough, open wide enough to see. I'll play that one again, actually. So we're laying her back. So the change of head position elicited upbeat right torsional nystagmus. And you know what? For the intents and purposes of this webinar, if you don't quite see it yet, it takes time to get comfortable and see nystagmus. I just want you to see it, and then we can get into analyzing it and get more comfortable later. So that's right upbeat. Left upbeat, be the opposite way. So it's pause, 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 and then there it goes. It's kind of jerking up and turning clockwise. Or if you look at, it's hard to see, but the eye's kind of jerking to our right, to her left, the top of the pupil. Okay.
Hey, Kregg, how do the patients feel when this is happening to them?
All right, well, getting some of the other videos, you can actually hear how they're feeling. So when you change the position, great question. when you change the position, if they complain of, if you see nystagmus, they'll be dizzy. They'll feel dizzy at the same time, right? It'll be simultaneous is, I guess, the word, okay? So they'll feel dizzy and you'll see the nystagmus at the same time, hand in hand, okay? Good question. So if you're doing a positional test, again, it's nystagmus and dizziness, they'll correspond. So what elicits the nystagmus? We saw in these picture or these videos, it was change of head position. You lay them back or turn their head. You can also see nystagmus spontaneously. So when we do our cranial nerve exam, we have them look at our finger straight ahead. And if we see the eye twitching, that's called spontaneous nystagmus. And that can be indicative of a central or a peripheral vestibular disorder, right? That by itself, we can't tell. We can change the eye position. We can have them do what we call gazebo nystagmus, where we bring our finger to the side to about shoulder level and have them look at the finger and see if there's any nystagmus. And then we'll go to the other side and see if there's any nystagmus. So change of eye position. It can come on with change of head position, which we saw in those videos. Pressure changes, coughing, Valsalva, tragal test, kind of bearing down. There's also other things that can elicit nystagmus too, like vibration and such. So there's different things that can elicit nystagmus. Most commonly spontaneous eye, head change, position, pressure changes, things that we test quite regularly in the clinic. And then these are the tests that you can do to elicit nystagmus. There's spontaneous gaze, head shake, Hall-Pike, roll test, Valsalva, tragal, and other tests. In a webinar for an hour, we don't have time to demonstrate all. That's a course, actually, that's a course in itself. And actually, we do have an online course that goes over all these tests. So if you're not familiar with them or you want a refresher, the Dizziness 101 course would be a great tool for you for that. But these are the tests that we use clinically and some other ones to try to elicit nystagmus or elicit their dizziness too. So let's get to what we came here for. We kind of have a bit of a foundation now. 3 ways to determine if nystagmus with dizziness is a red flag. And the 3 things that we're going to cover are visual fixation, 2 specific signs, and then we're going to compare BPPV, which is the most common cause of dizziness across lifespan, to central vestibular problems, okay? So with visual fixation, we're going to use infrared goggles. We need to use infrared goggles when we're assessing nystagmus and dizziness. And visual fixation is really in room light, you're able to focus on something. I'm able to focus on this paper clip here that I have clipped to my laptop. So I try to look at the camera and not to my left. So I can actually look at you guys when I'm doing my presentation. I tend to look at myself in the camera and not at the camera there. So when they're in room light, they can fixate on something. That's called visual fixation, right? And if we put a person in the dark, they have nothing to see. So visual fixation has been removed, okay? So if a person has a central vestibular disorder, if you see any nystagmus in room light, it'll be just as prevalent as when you put them in the dark and they can't see anything, okay? So with a central vestibular disorder, we won't miss stuff seen it in room light, but we may miss peripheral problems in room light, because with the peripheral problem coming from the inner ear, the nystagmus is less obvious in room light than when you have them in the dark. So when we put them in the dark, any nystagmus is more prevalent. Okay, so make sure we're not missing anything. We may not see nystagmus in room light. Put the blinders on, the goggles, we can see nystagmus with a peripheral problem. So we need to use we need to use infrared goggles. Or you may see the nystagmus in room light, but you're not sure, is that a central or peripheral problem? Put the goggles on, put them in the dark. If it's an inner ear problem, the nystagmus will be more pronounced. If it's a brain problem, it'll be just as pronounced as when they're in room light. So we'll go over that a little bit more, and I'll show you some videos to make sense of it. I like videos. I like seeing things. So I put some videos in here to kind of reinforce this material. And we're covering a lot too. So, and if you have any questions, feel free to ask or put in the chat. Otherwise, I just keep going, okay?
Kregg, I got one. It was a question regarding whether someone with a central brain issue causing nystagmus, would they feel dizziness with the onset of nystagmus the same way that someone would with a peripheral evoked nystagmus?
Good question. They may not. Yeah, and they may not because they're essential. They've adapted to it because they've probably had it for so long. For a peripheral problem, it'll be a lot more pronounced. The dizziness will be a lot more pronounced. Not all the time, but central problems, they may not even have any dizziness, but you'll see nystagmus. Can I get you guys give a high five or something to show that you're all, give Rob a high five just so we know you guys are still listening there. Give Rob a high five there just to make sure everyone's still awake. Getting some high fives there, Rob?
Yeah, they're starting to swing through there. A couple of thumbs up, a couple of claps.
Oh, thumbs up. Awesome. Okay.
All good.
Awesome.
Somebody just got kicked out. I'm going to try to get him back in here.
All right, let's move on. So we have visual fixation. Got to use goggles, okay? Just because if it's a inner ear problem, you may miss the nystagmus in room light. So here's what we'll see. We'll see a video to kind of reinforce that. So we have a gentleman here sitting. He's got his sunglasses attached to his shirt here, looking cool. Okay. He's sitting there. He's not moving, but we see left beat nystagmus. Spontaneous, and also when he looks to his left. When he looks to his right, it's not as pronounced, and that's typical. If you see nystagmus, I'm going to pause it here for a second. Pause it. If you see, in his case, left beat nystagmus, when he looks to the left, typically the nystagmus will be more pronounced. And when he looks to the right, it's typically not as pronounced. So just a little clinical pearl for you. I'll back it up to the beginning here. So you can see his eyes just flickering to the right of our screen or to his left. A little bit more noticeable when he looks to his left, less noticeable when he looks to his right. And then I'm going to turn a camera or a light on in there so he has something to look at. His pupils constrict. I don't know if you saw his pupils constrict. And then what happened to the nystagmus? It's not as pronounced. I can't see it as much. So that's indicative of a peripheral vestibular disorder. And here I got a top and bottom you can compare. Where he's in room light and when he's in the dark. When he's in the dark, the nystagmus is way more pronounced. Maybe if you guys could see that, maybe give Rob a high five there or a thumbs up. I'll play it again.
Yeah, those videos are great, Kregg.
So he's sitting there just moving his eyes, and we can see the nystagmus. And we can bias it. If we're not sure, have him look to the same direction of the nystagmus, and it'll be more pronounced. All right, so let's move on to the next slide here. So we talked about using goggles or infrared goggles to have visual fixation removed. And then also two specific signs that we want to talk about today is any pure downbeat, upbeat, or torsional nystagmus is indicative of a central sign, okay? And also direction changing, Gazebo nystagmus is a sign. So let's go to this video here. So downbeat nystagmus. I think you guys saw this slide or this video at the beginning. The person's looking up, looking down. They're looking to their left. Something's not quite right there. Some sort of nystagmus. Oh, he stopped. Looking straight ahead, looking to the right. Ooh, that's definite downbeat. Okay, for sure, absolutely. And someone called that at the beginning, which is awesome. So this person, kind of the case study behind them was another care provider referred this individual to me because they thought this person had BPPV. So I don't assume what people put on their referral script is actual case. Did my own history, and some things that I remember from the history was this person also complained of double vision, especially when they look to the side. Well, that's not typical with BPPV. And then when I did the oculomotor exam, I saw a downbeat nystagmus. So what do you guys think? What would double vision, especially when you look in the periphery, downbeat nystagmus, what would be some conditions that would cause that? Maybe in the chat there, see what you guys think. And then I did test for Dix-Hallpike for BPPV roll test. That was negative. So what would be some possibilities to cause double vision, especially in the periphery, downbeat nystagmus? We're not neurologists. We don't have to make the diagnosis, but just what are some of the options out there?
Oh, good. We got Central worried about MS, possibly a neuroma, possibly a stroke. Somebody identified maybe cerebellar. Looking at cranial nerve deficit and concussion, possibly.
All central stuff, right? This person, so what I did was, this person, it wasn't an acute. They've had this problem for a while. They were treated, actually it was a chiropractor that sent them our way. Been treating this person for a while. Thought they may have BPPV. And so once I saw this and ruled out BPPV, I sent a note to the physician asking for a neural consult and told the patient not to have manipulation to the neck until they get medically investigated. And so the physician set up the neurology consult, and this person has Chiari malformation. So which is, the foramen magnum's herniating into the cerebellum's herniated into the foramen magnum, and that was the cause of the problem. So it was a Chiari problem, malformation. So if this was, it just started a few days ago and I was the first person to see that, I would have sent them to the ER, right? But it had been stable medical condition, sent them back to physician, avoid manipulation, and get a neurology consult. So interesting case. So you will still see things, private practice that have been screened from other healthcare practitioners with a diagnosis of BPPV, but it ends up being Chiari. So history and exam are super important. So some tips, just remember, just reinforcing, if the nystagmus is from a peripheral condition, the nystagmus will be less prevalent in room light compared to when visual fixation is removed. If the nystagmus is up, down, or torsional due to a peripheral condition, have them look to the right, have them look to the left. Because if you see straight, say, downbeat nystagmus, if you have them look in one direction, if it's from the inner ear, you'll actually see a little bit more torsion. Have them look the other way, you'll see more of a vertical nystagmus. And I won't go into much detail, but if you're curious about this little tip here, we have a YouTube, like a little 2 or 3 minute tutorial on how to tease out the nystagmus when you see downbeat or upbeat nystagmus, just to make sure it's not a central problem. So if you want more information on that, just check out our YouTube channel and we'll have a video on that. So if you see nystagmus as pure downbeat, have them look to the side. See if you can tease out some torsional. Have them look the other way, maybe more vertical. So something to think about as well.
So Kregg, that's at North 49 on YouTube?
Yeah, North 49 Physio. Yeah, absolutely.
I'll type that.
So look up, we have a YouTube channel that's kind of made for care providers, but it's also made for the people with dizziness too. So there's lots of educational stuff that we can use as care providers, but also some things for patients as well. So take a look at it, and maybe some stuff you might find useful for your patients and useful for yourself too. So yeah, North 49 Physio. Hey, for the name, why North 49 Physio is because the Canadian border and US border is the 49th parallel, and Saskatoon's in Canada, so we're north of the 49th parallel. So that's where the name came from, because people couldn't say Ochitwa's physiotherapy, so North 49 was a lot easier. All right, so direction changing nystagmus. So let's see, we see this video here. So when they look to their left, can everyone see that left beat nystagmus? It's flickering to the left or our right, so it's the patient's left. We have them look to the right. It's flickering to the right. This person's in the dark because the pupil's pretty constricted. Now I'm going to open up the eyepiece in a second here. Pupil constricts. Let's have them look to the left and right again. I don't know if there's any change in the nystagmus. It's pretty much the same when they have room light or when they're dark. So that's a hardcore central sign too. And I'm not sure what the history was on that person, I forget. So some tips. Remember that with direction change nystagmus, don't confuse that with direction change nystagmus with the roll test. So with BPPV, there's lots of different tests you can do. There's a Dix-Hallpike, which is the gold standard test, and that checks the posterior and the anterior canal, and sometimes the lateral. The roll test is another test too for helping rule in BPPV with the lateral canal. And so if you have them turn to the right, you'll see nystagmus one way, and you have them turn to the left, you'll see nystagmus the other way, like we did in the video at the beginning. So that's direction change nystagmus, but that's with a change in head position. What we're talking about here is direction changing Gazebo nystagmus. So when I have them look to the right, I see right beat nystagmus. When I have them look to the left, I see left beat nystagmus. Their head isn't moving in space, it's just their eyes. That's a cardinal sign indicative of a central vestibular disorder. And then the nystagmus will be just as prevalent in room light as it will be when visual fixation is removed, if it is a central problem. And when you're testing for Gazebo nystagmus, just take them to shoulder level, right? So spontaneous nystagmus is straight, Gazebo is to the side about 30 degrees or level with their shoulder. If we take them too far, they may lose our finger, and they lose their finger and they're trying to find it, and we'll get a false positive. Or if they're wearing glasses, you bring them out to the side, they may lose your finger in the room with the glasses, so they're trying to see it. You may get a false positive too. So take the glasses off, just have them go 30 degrees either way to help prevent getting a false positive. All right, so just some tips for you with direction changing nystagmus as well. So case study, what do we got here? 2, 3. Oh, this is 2 weeks ago, okay? Or yeah, 2 weeks ago. So this person's laying in the right Dix-Hallpike. And in the chat, write what you see. Upbeat, downbeat, left beat, right beat, up torsional, left, upbeat, torsional.
Now, keep your head still. Can you just look to your left a little bit? Just your eyes. And look to your right. And look straight ahead. And look to your left a little bit again. Is it easing off at all?
Slowly. And she says easing off slowly, and it isn't as prominent as before. Let's just stop. Oh, it is a long video. Okay.
Most people
So
are identifying some downbeat here, and maybe a little bit of torsional, but unsure.
It's hard to see that. Like that exactly downbeat, absolutely right with the right Dix-Hallpike. So in my mind, is it a central problem or is it a peripheral problem? I'm not sure yet. So what are some tests that we can do to help rule in a central peripheral? How do we differentiate between the two? So what are some options based on what we've talked about so far? You guys put in the chat, what are some tests we can do to differentiate? So we see some downbeat. We've had them look to the left, had them look to the right, really hard, still seems downbeat, whichever way they look. What are some other things we can do? What are people writing there, Rob?
Some visual fixation with light.
Perfect. So Rob said, so this person had the blinders on, or they're in the dark. We could open up an eyepiece or put the light on, the fixation light on. In those goggles that we have there, there's actually a fixation light, little switch, it turns a light on so they can focus on something. One in each eyepiece, you could turn the light on and see if the nystagmus dampens. If it does, it's a peripheral problem. If it stays the same, high chance it's a central problem. Any other tips that people had there, Rob?
Question, would assessing saccades or smooth pursuit help in differentiating between central and peripheral?
Yep, absolutely. So we don't want to take one test on its own merit. We want to look at the whole picture. Absolutely, we're going to get into that. So I'm glad you guys brought it because we're going to talk about that exactly. Okay, so just get you guys thinking. This is what we see clinically, right? And what are some tests we can do to help differentiate it? Okay, you guys are on it. So I made a cheat sheet here that has nystagmus with Dix-Hallpike and a roll test. And then down the bottom, we have latency, duration, direction, fatigability, visual fixation, effect, with looking to each side, response to treatment. Hey, Rob, is there a way that I could share my slide notes with the participants in this?
Absolutely. What we can do is we can post slide notes under the recording that we're going to provide everybody for free who signed up. So anyone who signed up would be able to also access some materials as well as the recording. So yeah, we can take care of that.
So in the next 24 hours, I'll provide key clinical skills, my slides, a PDF of them. So you can have access to this cheat sheet, and then you can kind of reformat it in your own. And then we differentiate between central and then two different types of BPPV. There's canalithiasis and cupulothiasis. A lot of you guys sounds like you're pretty savvy with vestibular stuff. Some of us are more in the beginning journey of our in this area. So let's just briefly go over the difference between canalithiasis and cupulothiasis. Just a little quick picture here. With canalithiasis, the picture on the left, you can see, hopefully you can see, hopefully it's big enough, you can see little otoconia, those little calcium carbonate crystals are broken off, and they're basically free floating in the canal, and they always settle to the bottom, kind of like a snow globe at Christmas time. And then when you turn the snow globe over, it kind of resettles to the bottom again. So it'll always settle to the bottom. That's canalithiasis, and that's the most common form of BPPV. There's also cupulothiasis, and saying these words really fast can be a tongue twister. Cupulothiasis and canalithiasis. Say that 10 times real fast, tongue twister. With cupulothiasis, the otoconia are stuck to that cupula, or in this image, that blue membrane. It can be stuck on one side or the other. And so when a person tilts their head to the side, it kind of bows or pulls. Say if this is a membrane, if you have weight on it, it kind of sags it. Or if it's on the bottom, it'll sag as well and stimulate or inhibit that nerve in the canal. And that'll cause dizziness with nystagmus as well. So two different forms of BPPV. And we cover that in the Dizziness 101 course in better detail. And actually, I'm doing a BPPV course right now that I hope to have out in early New Year. That'll be kind of like a Swiss Army knife course, everything you need to know on BPPV. So with compare and contrast, when you change the person's position with a central problem, as soon as you change the position, they're going to get dizzy. With canalithiasis, there may be a delay for a second or two, which we saw in a lot of those videos earlier. And with cupulothiasis, usually the nystagmus and the dizziness is right on, like there's no delay. The duration of the nystagmus with central is persistent, it doesn't go away. Whereas with canalithiasis, it usually resolves within a minute, and cupula takes a bit longer. The direction of the nystagmus for central is usually uniplanar, up, down, strictly torsional. With BPPV, it's usually multiplanar, up and torsional, down and torsional. Unless it's the lateral canal, it'll be lateral. Fatigability, what I mean by that is with repeat testing, does the nystagmus become less obvious? And with essential vestibular disorder, it'll be just as prevalent, the nystagmus, from the first time as to the 5th, the 10th, whatever many times you do it. Hopefully you don't do it 10 times, but just as an example. Whereas with BPPV, if you keep testing it, the nystagmus isn't going to be as obvious. It kind of dampens with time. Visual fixation, we talked about that. It'll be more obvious with BPPV than it will be with a central problem. And then we can also tease out if it's downbeat nystagmus or upbeat nystagmus. We can have them look to the right or left to see if we can get a little bit of more torsional component. Like I said, we have a YouTube video on that. And then if you're still not sure, you can always do a maneuver and see what effect that has. Because with BPPV, they're fast responders, right? Really with treatment, you want to determine who's going to be a responder. Is it going to be fast, slow, or are they a non-responder? And BPPV is a fast responder. 84% of people are better after one treatment, right? So treat it, see if it makes effect. If they're better, they could have BPPV. It's no effect, then more likelihood it's a central problem. So just a little bit of compare and contrast there, a little cheat note for you. So we covered the 3 things: visual fixation, 2 specific signs, downbeat, direction change in nystagmus. We compared and contrasted BPPV versus a central vestibular disorder. And then we talked about putting everything in context too. Someone brought that up with other tests, but also to their history. And remember, patients have all the information that we need. We just need to pull it from them and ask the right questions. So is there any other 5Ds? Is there any other, what's their medical history? What's the onset, duration, all those types of things? We need to paint a picture. And we also need to put things in context too. Don't just hang your hat on one test. Does it fit with, is there other oculomotor signs too? Smooth pursuit, saccades, like that person said. Awesome. And you also have to remember too, that person could have more than one reason for dizziness. They could have a central problem and BPPV, or they could have a central problem and a non-vestibular problem too, right? So history taking examinations is very important to kind of tease these things in and out. That being said, with nystagmus, we can also have false positive tests too. Just like an MRI, we don't, if someone has back pain and then they have an MRI and it shows a disc herniation, that doesn't mean they have surgery, right? The MRI has to correspond, or correspond with the history and examination, right? It has to fit, right? And same thing with the oculomotor findings. You may see sometimes there's false positives. Does it fit? If it does, great. If not, it's probably an aberrant finding that isn't relevant. Some other clinical tidbits. Do you guys ever have those patients with the droopy eyes? The eyes kind of, right? Some tricks I can do for that if I'm looking for spontaneous and Gazebo. I'll just hold their eyelids up, right? And have them look for spontaneous and gaze evoked. Okay, so just grab the eyelids and pull them up, all right? And if you don't have infrared goggles, a little hack that you can use for looking for spontaneous and gaze, it won't really work. It'll be hard for like Dick's Hall Pike and Roll test, is you can actually have them cover one eye and use an ophthalmoscope and then cup their eye and use the ophthalmoscope so they can't see anything. They have one eye covered and you cover the other eye with the ophthalmoscope. Have them look straight ahead, see if there's any nystagmus, have them look to the side, see if there's any nystagmus. It's kind of a hack that you can do. But then again, that's not really, won't really work well when you have them moving. It's good if they're stationary. So goggles are the way to go that way. When to refer? We kind of talked about that a little bit. When there's the other 5Ds, query migraines. Migraines are huge. Like when I started taking vestibular stuff, they didn't really talk about migraines. It was BPPV was number 1, in-ear infections number 2, Meniere's is number 3. I think migraines is probably is way up there. It's number 2 or 3, at least clinically what I see. Is there other neurological findings? then consider neurology. If it's recent and you're the first person to assess it, send them to the merge. If they have other oral symptoms, so oral means like ear pain, pressure, ringing in the ear, hearing loss, send them to ENT or otolaryngology. That being said, I always check their jaw first because someone can have dizziness and a temporomandibular disorder, right? So I rule out the TMD stuff as well. So if people are dizzy and dizzy when they move, vertigo when they move, those are people I love to see. But if they have dizziness and something else, like dizziness and double vision or facial droop, I'm thinking, neurology. If they have dizziness and hearing loss, I'm thinking ENT. That's kind of how we do things at North 49 there.
Craig,
So,
quick question regarding migraines. Will people have nystagmus only if they're experiencing their migraine symptoms, or will they also have nystagmus when they're feeling better, when they're feeling well?
I can tell you what I know. I can't answer. I know that from talking to other people, when they see people with migraines, they will see kind of weird things that don't fit. But I haven't asked if that's when they're symptomatic in an acute episode or not. So kind of answers your question. But really, with migraines is a cranky brain. The way I look at it, migraines is cranky brain, Meniere's is cranky ear. Cranky brain, so structurally there's nothing wrong with the brain, but it's firing not right. So some people have said that they see nystagmus as kind of doesn't quite fit or a particular problem, but I'm not sure if it's during the acute episode or not. So maybe would be my answer to that. Okay.
There was Helena mentioned that she's seen some research from a Shen Bei, BEH, who says that they can have nystagmus between migraines as well.
Awesome.
With the cranky brain idea there.
Yep. Mm-hmm. Thanks, Helena. Yeah, he's kind of the migraine expert. And if you can read some of the stuff, it's great. And it's something just in the last couple of years, I've been more exposed to it. And like I said, training 20 years ago, we didn't talk, not that long, but 15 years, we didn't talk about it. We're learning a lot more about it. I'm constantly learning about it too. So thanks, Helena, for that input. That's awesome. Any other questions about migraines or comments too? Because we learn from each other. You know what? Actually, who learns the most when they teach? When I teach, I like teaching because it forces me to learn, right? So this is an opportunity for us to learn from each other. So any other comments, insights, or questions regarding migraines?
Just waiting for some chat to come up there. I do know that Jack and I are friends down in Australia, Toby Hall and Kim Robinson, who've looked at the C2 snag for cervicogenic headaches, have identified that somewhere in the range of about 30% of people are experiencing dizziness in their population because of cervicogenic issues, and that they're using that headache snag to also address cervico-related dizziness.
Yeah. The vestibular system consists of the neck too, right? People just think it's the brain and inner ear. It's the neck, it's the eyes, it's the somatization in your leg, it's more than just those two systems. So the neck, so yeah, good point. The neck can also be a source of problems too. So we're going to round back to the videos that we saw at the beginning just to kind of reinforce some of our learning. Let's see what we see now. Hopefully you guys have your sticky notes from before and you wrote down what you see and what you think is causing the nystagmus. So which way is the nystagmus beating with this gentleman? I'll show it again. What are people thinking? Is it to his right or to his left? What are people telling you there, Rob?
right side has been identified a couple of times there.
Yeah, I would agree. Okay. Do we know if it's a central peripheral? No, because we don't know what happens when he has visual fixation, right? So it could be a central, it could be a peripheral. We don't know, right? But you guys saw the right beat nystagmus. That's all I want you to see with that one. This one I think we've seen twice before, but I'll go through it again. I think everyone can agree that's downbeat nystagmus. That's the one we had a little case study on. All right, we're actually past 8. I had other ones too, but you know what? I'll show you some resource you can go to later, unless you guys, and if you guys want to, we can go through the questions and I can go through some of these later people want as well. I had 3 extras just as filler in case we were going too fast. So I have some other ones there. So really, the objectives that I had was that you feel more comfortable analyzing nystagmus, that, okay, you know, if this is something new to you, okay, I feel more comfortable, or if you've been doing it for a while, reassured that I've seen things as I should. Develop, understand how to use nystagmus to determine if the dizziness is conditioned from the inner ear brain. Just got some things to tease things in and out, and overall just more confidence in knowing when to refer as well. So those objectives that I had. Resources kind of moving forward, some resources that we have at North 49. Basically, I'll just click on this. Well, I'm not sure what will happen when I screen share. Let's see. Ooh, okay. All right. So we do have a website that has basically online courses that we have, vestibular ocular library. So if you want to look at some more videos to have as a reference or test your understanding or to show your patients, we have a whole library of positive vestibular ocular findings. Not sure what course to take next. We have a dizziness quiz that kind of helps you determine what courses you should take. Courses that we have taken that we personally recommend, that we've taken throughout North America, based on if you're, you need a foundational course, intermediate, or advanced level course. We also have a monthly subscription. It's free. It comes out once a month. We don't bombard you with emails, because I don't like that when people bombard me with emails. As soon as I sign up for something, it's just once a month. Has like 3 or 4 just different topics to help improve your skills and your ability to market them. That's a free monthly email subscription. And then we also have our online course. We have in-person courses, a little bit tricky with COVID. We've morphed it into hybrid courses. I've done a couple of those since COVID. And then I've developed that Dizziness 101 course, which actually we'll go right to it here. Basically gives you a framework to help guide and assess your treatment of dizziness. And really it goes through the epidemiology of dizziness, cause of dizziness, how to take a proper history taking, some functional outcome measures, and has downloadable videos on how to do all the ocular motor tests, and then how to treat the most common form of BPPV. And in the course too, there's heaps of downloadables, PDFs, cheat sheets, bonuses, medical images of the vestibular system that actually we had made professionally for this course. So you don't have to worry about copyright and royalty infringements. You just download them. I made them for you guys. Use them. So that's part of this webinar. I think we have, I know we guys have access to that, and they get a 10% discount on the price of that course there. So that's that. I'm going to go back to my slides here.
All right, Craig, that's great. What I did is I did tell everyone that we'll be sending out an email, and we'll make sure that we include that discount code. So for everyone who signed up, perfect. And I've got a question in from someone. If a patient has both some central evoked nystagmus as well as some BPPV, is that going to change their Dix-Hallpike findings?
thinking about if I've ever seen one. It could skew it for sure. If someone has like a lateral nystagmus, it could skew it. Absolutely. But what I do is, if it's BPPV, you treat it and then see what the oculomotor findings are after it. So definitely it can skew it. But one thing you can treat quickly is BPPV and see if that changes their nystagmus after. So answer is yes.
And that's a great point. Looking at the concussion patients as an example, is that deal with the lowest hanging fruit that you can, and then see what's left over. And rather than trying to try to fix everything at once, that's a really great point there, Kregg.
Or even too, if it's concussion, people, we want to wait, wait 7 to 10 days. You don't want to provoke symptoms. Well, if they're dizzy, check the Dix-Hallpike and roll test, rule out BPPV, because again, you can make a rapid change. And why wait 7 to 10 days? You can treat them no problem in the first 7 to 10 days if it's BPPV, absolutely. And also too, treat their neck too in the first 7 to 10 days, because that can be a big source of symptoms and driver. So any other questions there, Rob?
I've got a lot of platitudes. Everybody loves you. Not a lot of hard-reaching questions quite yet.
Hopefully, feel free. And two, if you guys have questions, I'm like, it's kind of ironic that I'm the guy speaking, but actually I'm kind of a quiet guy. When I'm at a course, I don't like asking questions. Feel free to ask. But if you're really shy too, you can always email me. And I can, just search our website, or you can even reach out to me and direct message me on social media, whatever, just so we can kind of get at some of those burning questions. And if you have a question now, you know what? There's usually probably 2 or 3 other people with the same question. So don't be afraid to ask.
Great. Helena,
no questions there, Rob?
Helena actually answered in the chat regarding the question about BPPV as well as central, and yeah, agreed with what you said. Treat what you can treat, and then see what's left over. That's good. Hey, that's great, everyone. So what we'll do is we'll include Kregg's website address for North 49 in terms of our follow-up email. We're going to include the directions on how to access Kregg's slide deck in terms of when we post that. We'll include the 10% discount code and info on how to access Dizziness 101, as well as the other offerings that Kregg's got in terms of a follow-up email. So that's fantastic. Thank you, everybody. Kregg, anything?
Awesome. Thanks for your time, guys, and sticking in. We've been just over an hour. I apologize, but you've been a good crew, great crew, and yeah, thank you for your time, and I hope you guys got something out of it.
All right, everybody. Thanks a lot. You'll get an email from us in the next 24 hours with all that great info. And yeah, thanks very much for joining us. We'll make sure we push out some info as well as on our next free webinar. And in terms of just trying to bring some great thoughts in physiotherapy to the physiotherapists and connect as best we can. So thanks, everybody. Have a great evening. Take care.
Take care.